Let's consider variance here. So I'm back in the base case, 2 hours dedicated to each track, one anesthesiologist and one surgeon. First thing I want to do is I want to think about partitioning the variance. So currently, the patient stream that's entering both tracks is identical. But my question is, what if I were to, favor the lower BMI categories in track A and push, the higher BMI categories to track B? Is it possible that I may sort of squeeze out an extra surgery in track A without, doing any worse in track B? Really not saving any variance here. I'm just sort of, unpooling the patients, so lower BMI, track A, higher BMI, track B. So I've done a little calculation here. This is the previous calculation we had where we basically pulled all of our customers and we calculated the mean and standard deviation. But I've got 2 BMI groups. In fact, I've got 5 BMI groups analyzed here as well. So the idea is this: if I were to take 50% of the patient count, starting from underweight, going up to normal weight, you can see that I'm going to, in fact, have to take even some obese into track B, 5% to be precise, because that's what gets me 50%. If I add these up, 1, 14, 35, I get to 50%. And what I'm going to do is I'm going to do exactly the same calculation I had previously for the entire patient group, doing a weighted mean and a squared weighted variance, and then of course the derivative standard deviation. Doing exactly that. And when I do these calculations, I get 97.62 down from 100.71, right? So if I go to the single proxy, 100.71. Now I've got 97.62 with a smaller standard deviation, 678. And then for track B, it goes up from 100.71 to 103.8, with a standard deviation of 1341. So in fact, I want to use these numbers, 97.62 and 679 in track A. So let's just make a note of them. This one is 103.8 and 1342, let's say. Everything else remains the same. The surgery time is just going to change, 97.62. And deviation is 679. And this is the one where the heavier BMI folks are going to go. Into go ahead and run this for you. So this particular proposal of unpooling, pushing heavier BMI patients into a particular track attracts criticism from some. Medical professionals who see the merit in having special equipment for morbidly obese folks, bigger operating tables, better lifts, and so forth, catered to the heavier body weights, as being something that's actually ideal. But there are potential sort of acceptability considerations around this. So I'm going to leave that for you to debate. But the question is, whether this idea has any merit to begin with. It's a partitioning of the variance. And I'm going to run this to completion for you. So I got 5 and 4 with over 200 flow times. I'm going to do one more. Well, actually one more after this. And in this particular instance, I got 4 and 4 with, again, over 200 flow times. So it's not alleviating the bottleneck. And we're not even getting a win on A, right? I was hoping to get squeeze out an extra surgery. So where are these fifth patients? They're in fact stuck in surgery and they're about equal. So although I was trying to favor A with these lower means and standard deviations, in fact, that's not really playing out. Try one more. At least it's not playing out in this particular run. And I'll do one more run here. Because I now got 4 and 5, totally counterintuitive, right? You would think that A is going to beat B. So it doesn't seem to be a super useful initiative doing this partitioning the variance where I, try and break this, this patient stream up into different BMIs. I'm going to show you one more idea, and you certainly can try it. It's quite a bit of work, perhaps to implement it. Even think we can implement it directly in the simulation as is, but had the idea of, taking the very lightest BMI folks on Mondays. This would be their mean standard deviation, so that would be all the underweight, all the normal weight, and some of the overweight, and then doing the next 20%. So in other words, 20% of the patients on Monday, lightest BMI, and then the next lightest BMI, which would be the overweight folks, and Tuesdays, Wednesdays, and so forth. And then on Fridays, you'd be looking at, morbidly obese, all right, 20%. So it's another way of partitioning the variance. Not clear that it's all that meaningful performance-wise. So I'm going to go back and rewire these things. So there's it was 100.71. I think it was 8.09 if I'm not mistaken. But as a last variance matters consideration, I wonder, if we spend time with maybe a Six Sigma project to reduce the variance, maybe acquiring equipment to specifically to hire the most variable of the patients, which would be those morbidly obese folks, so special lifts and operating tables and whatnot, whether we can justify a reduction in the standard deviation. So I'm going to see if instead of 8.09, let's say I can get it down to, let's say 3. Does that make a difference? Okay, so I've got 4 and 4. This is now base case, but just reducing the standard deviation of the service times. So it didn't look to be all that helpful. 4 and 5. 4 and 4 again. So you'll have to do the work. As the things now stand, it seems like alleviating, resolving the utilization is priority number 1. You know where to land on that, anesthesiologists. Okay, so in the next clip, we'll look at psychology matters. And then there's a last clip on optimization. There's a built-in optimization tool here.